I think we're going to have a real treat. India's journey with ROP from Professor Azad. So we look forward to his talk. Sir.
Good. So basically, you know, what I'm going to tell you in this presentation is, kind of it may be my journey, you know, to retinopathy of prematurity. And it also will be the journey of India, and it also will be my journey on the global platform. So that is what it is. This is an oft-repeated slide. And where you can see that South Asia, it harbors 32.5% of total blind people in the world. And the prematurity in India, when we consider in the the landscape of global prematurity, it is almost approximately 25 to 30%, maybe little, because it's here mentioned here less. And the ROP blindness is also a good number in our country, which is 15%. What are the challenges we have in front of us? Our challenges are the effective early detection and treatment, and which means effective screening. The next challenge is about the awareness. We often talk, I think in the previous talk also, previous session also you must have heard. And then there is a lack of trained manpower. And Subhadra has gone, she is the one, who is involved in, good number of trained people all over the country. Of course, I am also one of them. But I give credit to Subhadra, because she is Jhansi ki Rani for our retinopathy of prematurity. She is coming there. So these are the three challenges in front of us. First is the lack of screening. This is just a data to give you impression that how much important is screening. This is a study we did in RP Center where Parijat was also, Parijat was with me, and he used to, take all the brunts of my patients and also the work and all this. So you can see here that 32.48% were both high stage 5. Both high stage 5 means you are blind, totally blind. And the mean PCA was 7 months after, the birth. And the delay was 6 months. Like after 6 months, these babies and the parents, they report to you. And the common risk factor was oxygen therapy, which was 80, almost 90%. So this is something which is very, important. And out of this, again, another 90% where babies were not screened. So that is the problem of screening, the challenge of screening. The next was awareness. We also looked into it, and we found that 86% of babies which were referred to RP center or a big tertiary care center, they were referred by ophthalmologist, 8.7% by pediatrician, correct diagnosis by 4.3% ophthalmologist. Of course, this is, 2016 and now 2024. So a big, gap of years are there. But nevertheless, we still have a problem of correct diagnosis. And then metropolitan city like Delhi, it shared 30%. It's something very startling. And 90.3% of these babies were blind. So we have talked about screening, we have talked about the awareness, and this is a public health problem in the developing world. An ROP child will remain for 60 years blind for 60 years. We talk about the cataract blindness. Cataract blindness, normally people are above 60 years. Here we have a baby born with blindness, which is much more devastating, not only for the person, for the baby, for the entire family, and for the entire nation. I have just this, a very, what you call as a modest workout, maintenance costs 2,000 per month and 4,000 rupees altogether with productivity. And this will amount to 28.8 lakhs, which is 37.600 US dollars. And the average cost of treatment is only 15,000, maybe this side, that way, a little bit more, little bit less. So this gives the impression that, treating the baby, bringing them out of blindness is a very small amount as compared to the burden which will be faced by the society, by the family, and by the nation is too big. Now, I'll talk about our country, what was the neonatal situation, and it was limited to major cities and only few ophthalmologists. I should not say 2 to 3 ophthalmologists. I wanted to correct it, but I couldn't. And a few ophthalmologists, maybe 3, maybe 30, whatever it is, and Center of Excellence for ROP developed in RP Center, PGI, LV Prasad, Shankar Netralaya, and many other places. And screening started to expand. And then what came to my mind was that we should have an awareness workshop, because screening, awareness, and a public health problem, these were the 3 main issues. And so we, started a unique concept of having a paired workshop where the ophthalmologist and neonatologist will also be there. The basic reason was that neonatologist or a pediatrician, he sends ophthalmologist these babies, and I always say this is a gift from the neonatologist or pediatrician to us. So we should treat the gift very well. So we did this workshop. Another unique thing we did was we did an assessment, what the impact of this workshop on the audience or on the participants, and we found it was highly significant. We had this workshop earlier with the Government of India and WHO. I think I went to many places like Mysore, I went to Patna, I went to Lucknow, I went to Bhopal, I went to Delhi, and many other places we went. I think in Hyderabad, Subhadra, maybe in 1999. So we did all this workshop, and a lot of people, got aware, not only ophthalmologists, but other people also. And then Sightsaver, they got interested, and they, took part in propagating this, message of retinopathy of prematurity. These are the places where we went 2008 to 2012. Pune, Lucknow, Mumbai, and all this mentioned here, I did not tell you. And this trained 650, I'm saying, but maybe much more, maybe around 1,000 people were trained. After 2012, the Government of India started these SNCUs and level 2 SNCUs to address the neonatal mortality. Mortality rate has come down. I think, how much is mortality rate, Subhadra, now? I think, yes, 12 to that, but 13%. It used to 70%. So basically, neonatal mortality is related to retinopathy of prematurity. So the 1,000 were planned SNCUs, and however, now most of the SNCUs are in place. And ROP was included as one of the 30 conditions of children in the RBSK Child Health Program. Means Rashtriya Bal Suraksha Karyakram is the RBSK. And the Government of India initiative took in preparing a national task force. Of course, I was advisor to Government of India at that time for blindness program, and I specifically said that ROP should be there in the national task force should be made, and we prepared the task force. And all people who are sitting here were in the part of the workshop and part of the this technical group, expert group, basically for preparing a guideline for program implementation, competency-based training curriculum, monitoring and evaluation, and advocacy and communication and program monitoring. These were the few aspects which we entrusted to the National Task Force on Retinopathy of Prematurity. In between, the Queen Elizabeth Trust came in And they said that we want to support this program. ये क्या हो गया? अरे, what happened? अरे इसको ठीक करना जरा. एक मिनट, just 1 minute. Okay. So Trust supported this program, and Trust, they, did a bi-pronged approach. Means they took neonatal care mentoring institutions, and they also took into account the eye care institution centers, basically for training in ROP screening, and neonatal care for quality improvement for neonatal teams. Basically, ROP, one side is the prevention, and the other side is the management or the treatment. The prevention will more come from the neonatal side, and that's why the Trust program, they took both the aspects into consideration, and these district SNCUs, they were linked to the medical college. So that was the concept with which the Trust helped us. And then the program is still going on. Lots of other things are coming. This is very important, National Committee and Guidelines. Then I did Asia ROP Survey 1. I am not showing the details of that, but I'm just telling you that countries where national committees were formed, or where the national program had included retinopathy of prematurity in their program, there the ROP prevention and ROP blindness has come down considerably. And these are the countries, national guidelines, almost all countries. Now the Bangladesh also has a national guideline. Subhadra, I think Subhadra was there who possibly released the program. I don't remember. So basically, those countries which people have now, their own guidelines are there. Now, I try to augment this ROP education on global platform. We had, rather going into this, we had first ROP, and International ROP Prematurity was held in Vilnius, Lithuania from September 14-16, 2006. 260 participants from over 50 countries. Rasa Bagodini and Rasa Sirutini, perhaps these are sisters, if I'm correct. So there are special efforts of these two Lithuanian ophthalmologists, and they, organized the first meeting of retinopathy of prematurity. Second ROP meeting, I was, fortunate to organize in Delhi. It was a big, the MF Chang, who is now the director of NEI, he was also there in that meeting. And many other people, Wai Chi Wu was there, and many other people were there, yes, Mike Tracy was also there. I, invited him, and he was there, so kind of him to come. And it was a, big meeting. And these are the pictures, maybe Subhadra maybe somewhere here, and maybe Karobi maybe. Parijat, of course, has to be there. Mangat Dogra will be there, and Anand will also be there. So third international conference was organized in Shanghai. And Shanghai was the place, where Pekin Chow, he is there in that hospital, and he is a good friend of mine, although he says he is my, student or mentee, but whatever it is. So he was there, he organized this meeting, and wonderful meeting was there. And this is the picture, this is Pekin Chow, and this is the group, the audience which is there. And the fourth international meeting was held in Cancun, where I was there, and many other people, Subhadra was there, Anand and Dr. Dogra. And here we had breakfast with experts, workshops, presentation, posters, free works, and discussion, and panels were presented. And Marilyn Miller. Marilyn Miller is alive, Subhadra? I don't think. So she was very kind, even in our meeting in Delhi, she had given some travel grants to us, which we had given to at least 5-6 people, young people. We had given travel grants in Delhi when we had organized. And Marilyn Miller, I think she was not there, but she was there. She's mentioned, yeah, she was there. And banker, our banker, no, his name is banker, but he is not our banker actually. I want him to be our banker so that society grows well,
I'm a banker for my program.
Anyway, so that is that. This is the Fourth World Congress in Cancun, Mexico. It's a beautiful place, Cancun. If you have not gone, you can go there. And of course, you can enjoy the beauty of the sea beaches. You know, our hotel was on the sea beach, and many other good things are there. Another thing is there, the culture of, Mexico is very much similar to ours. There's a Mayan culture, you know, Mayan culture and our culture, वहाँ भूत प्रेत का वहाँ भी है. There is a place where Bhoot Pret center is there. And like that, you know, I mean, those things are there, you know, which aligns our culture to the Mayan culture. And the Fifth World Congress, very recently we had in Dubai. And Dubai, of course, everybody wants to go there. And we had a good meeting there in a short notice. And we could have so many people. We discussed so many things, so many new things came. And that was the place where we found the World ROP Council. And this is the charter which was signed there. And the next meeting of World ROP we are going to have in Italy mein jagah. Florence. So we are going to have this meeting in Florence this year or next year? This year. So we will give you send you the announcement and the information. And of course, Florence, I have been there. It's a beautiful place. And of course, that is there. So this is World ROP Council. And then we come to our own, this IROP. As I said, this is a family. We are having a consensus meeting at 3 o'clock. And we meet every year. And we had a first meeting in Bangalore. And courtesy Anand Vinekar, because he's very kind and he organized the whole meeting. I think, of course, how many people were there? 30 people? 38. And how many people are we now? 223. So you can, multiply how many times from 30 to 200. Kitna bar hua? Anyway, first meeting in Bangalore, second in Pune, third meeting in Raipur, fourth meeting. Pune meeting was organized in HV Desai Hospital. And I remember first time, I took my video indirect. And with video indirect, I showed them the ROP, the area on the screen. That was first time it happened, and people were very happy. And since then, a very good ROP program is now being done in HV Desai Hospital in Pune. And then Raipur is Anil Gangwe's place. And that meeting was also very good because that's a very organized, center. And with Anil Gangwe there, he is also dedicated like Anand Vinekar. He may be a small model of Anand Vinekar. No, I'm telling you, this is what is true. It is true. And then we, of course, Chandigarh is there, and the lion of Chandigarh, and the master of, the ROP ceremony is Professor Mangat Dogra, a very, honored gentleman and very sober, but yet very effective and has a killing, instinct. So that is what Professor Mangat Dogra is there. And with his, organization, with his, host, we had a very good meeting there. And then, of course, Dubai was no man's land because we are not there. So I took the mental to organize it there, and I did it. And then next meeting was in Surat. She is sitting here and smiling. And she did a wonderful job in Surat. And of course, Anand was after her to do it better. And the next meeting we are having in Chennai. And what is the date? Huh? July 12th, 13th. I'm sorry. I should know, and I'm asking you. But anyway, so 12th, 13th is the meeting there in Chennai, and it is with the Shankar Nethralaya. Shankar Nethralaya meeting is also in pediatric ophthalmology. ROP only. So ROP is there, and ROP is here. So ROP there and here will make it very big. These are the awards. There are 2 awards we give every year. Professor Rajwardhan, sorry, my name. And this award is one from Taiwan, then China, Michael Sapiro, and Bangladesh, and now the next one will be from Japan, and that will be in China. We keep on doing something, some research, and we do some publications. A lot of those have gone. I don't want to go into the details, because if you all can see there. Thank you very much. And my time is up for a very long time. They are showing me time is up. So time is up. Thank you very much.
Thank you very much, sir, for showing us the entire journey, not only yours, but of ROP in this country, and how, especially with your effort, so many things, and it became now today IROP society, which you can't imagine. That retrorental fibroplasia, one para used to be there, and that is where you have taken it. Thank you very much. Now, I think Subhadra has to go to a next session, so I would request Subhadra to come forward and talk on setting up a training program for newborn blindness prevention.
Thank you. So I'll just be talking a little bit about what all goes into the training. I think the inspiration is from our polio control program, which occurred in an era where there was no internet, no cell phones, and still the world got together and we were able to conquer a deadly disease like polio, and it is depicted here how we conquered polio. It was because of the foot soldiers, the health workers, who actually conquered polio, and the development of a two-pronged needle. That means technology with tenderness. That is what on the field helped us to conquer polio, and that is what inspires us, that is how we are going to conquer this severe epidemic of blindness, which is not there at birth. I just want to correct that ROP is not a congenital disease. There is no blindness at birth. It is a postnatal disease. So what we need to do is to develop a lot of human resources to tackle this program. Of course, the ophthalmologist will remain at the forefront of the management, but I think the screening needs to move from ophthalmologists to the health workers on the ground. Then only the large number of children will have access to care and screening, because screening is the crux, but the number of children who need treatment and with improved neonatal care would become less. So the ophthalmologists are not the correct people to actually do all the screening. They should still monitor the screening. So we need to rope in, and we've already done that, to rope in general ophthalmologists who can do the screening, or the optometrists, the nurses, technician, photographers. So various models can be there. So the good thing I think is that after COVID, everybody has learned to take good photographs, the general people. So you really don't need to train them that what is a good photograph, how to store, how to forward, how to edit, all that they have learned, the technological part. So we just need to train them how to do good photography of the retina. And in addition to that, the program doesn't end there. You need to have a whole army of people who are going to then follow up these patients for their refractive error, their optical glasses, their rehabilitation, low vision, and of course the neonatal anesthesiologist, which used to be a rarity in ophthalmic hospitals, and it was a big struggle to get them to come and operate our 900-gram baby or 1100-gram baby, and still it's a struggle for many doctors where the pediatric neonatologist, anesthetists are not willing to come to an eye hospital, or the eye hospital is not willing to take that risk of taking care of these babies. So that will remain. So there are various education programs you already heard, like CMEs, short-term hands-on courses, which can lay from 2 weeks to 3 months depending on what the candidate wants to learn. We have been running a very successful 1-month hands-on training course. There are others who have different courses. We now have surgical courses for 3 months. So depending on the pre-existing skills, I think the candidates who come for training should be very clear what all they know, what all they don't know, what they want to learn, so that their time is optimized along with their mentor. And of course, the curriculum should be very thorough. When the candidates come to a center for training, it's the duty of the mentors to have the curriculum, the lectures, brochures, give all the pamphlets, all the PPTs to your students so that they can really make best of it. And we've made it a mandatory rule that in our institute, there's no copyright on the posters, on the pamphlets, on the slides. I mean, anybody, they're available on the net also, YouTube also. You can just take them, please use them for your babies. Then we need to teach them the clinical methods, and in clinical methods, just not look at the retina, but how to carefully handle that baby, talk with that baby, talk to the parents. It's a very stressful situation for the baby and parents. So part of counseling and caring for that baby with your heart and hands and head becomes very important in this situation. Then how to handle the diagnostic equipments, whether it is photography, different types of photographic machines now available. Then the surgical trainings, which we go through simulators, wet lab, and assisting the surgeries and picking up surgeries. And then the art of patient care, how to manage difficult situations, failed surgeries, apnea, deaths. So many things will happen. So we should have a coordinated team and program how we are going to handle that. So during the training, we train the trainees how to handle all these difficult situations, because everything may not turn out well. Then the social, economical, surveillance, administrative aspects, because you will come up with barriers with the government, with the RBSK team. So you have to really learn how to tackle all those situations, because if you are going to go into the public. So the bedside training is very essential. So from beginning, we feel that the program should be in the NICU. It should be NICU based, and that is where the whole thing should happen. And slowly the onus of screening and getting those babies should be handed over to the NICU. So now with the cameras, we are now training the nurses and the technicians of the NICU itself, and they should take over the screening, just like they have taken over the screening of cardiac defects. They don't call cardiologists to do the 2D echo now. They do the 2D echo. Once they detect a problem, they call in the cardiologist. So they should be doing the screening and doing the photography and learning how to interpret these images and call us only if treatment is required. And during the training, the manpower, whichever is there, they should have a whole team so that they can set up the program. If you just train the fellow and then they don't have a setup and the other team members are not trained, then they cannot function. They cannot function in isolation. So training of whole team. And while we do the training, there should also be an evaluation of your training system with feedbacks and trying to improve, and then once they go, there should be an exit evaluation. What are the competencies, whether they can do, not do, where do they need further training or further refinement, and that hand holding when they go back to their place. Now with the imaging system, you can send the images, you can call us, we can counsel, and we can, guide you. So that works. Of course, today I think nobody should say that we are not able to do a fundus photograph. So many tools are available, small ones with your smartphone, and adult cameras and pediatric cameras. So we should try to image, we should try to take pictures, when you're asking for second opinion or something. So there are so many cameras there, and then, we can follow them. If you take pictures, then you can follow them up much better than if you cannot. And the last but not the least, to take good care. The candidate should be so well trained, like Viju Raju, who can treat their own child. Within a month of finishing his fellowship, he was able to take care of his own one disease. So that's the level of competency we want at the end of a good training program, hand-holding, treating, and building the whole team for the city or the town or the NICU. So that whole program should be brought to forth for the whole team, and then it really helps. So I think there are still gaps in the curriculum. We can't keep on doing this firefighting for decades. We are already doing it for 30 years. But I think the baseline, when the curriculum is being developed for the DNB candidates, for the MS candidates, fortunately in ophthalmology it has come, but still they don't have practical exposure, but at least the sensitivity, but it should come in the DNB of the pediatricians also. So I think I'm most happy with all these fellows. They are pioneers of change. Once they train, they set up their own program, and then they train more, and that is what we should encourage. So I trained 2 people from Bangladesh. I got 20 applications. Please train us. I said, no. Now you train with them, and once they train you, then you can come back for a 1 week polishing with me. So that way we could train 20, 30 people there within a manner of 2 years. So I think these students, once they get trained, they lead us more further. They have more innovative ways. They are better than us. And this is Smarth Agarwal, who, put up these posters on his car, which I never thought in 20 years. So, when you train people, they really take your program forward and give you great joy. So let's go. Thank you. So I have to go, but I'll try to come back.
Thank you very much, Subhadra, for a very short suite. I was expecting more from you, but I believe you are very busy. So maybe next time, no problem. Thank you very much. So the next speaker is, of course, your, shortening your lecture will help Karobi, because Karobi is, gives long lecture. So anyway, so now Mangat, Professor Mangat Dogra is in front of you, and he'll tell.
Thank you, sir, for this opportunity. I think we are all passionate about the subject, and we know that we have a problem in this country, that this is becoming a leading cause of childhood blindness. And we also know that heavier and more mature babies are developing ROP, and it is becoming a big major problem for the public health problem. The risk factors, in fact, the basically which are relevant to us is, of course, increased survival, because Professor Azad mentioned about SNCUs. The mortality has come down, infant and more are surviving, and inadequate quality of neonatal care. Some of these SNCUs are managed by medical officers. So that is where we are. And the oxygen is 100% given. That is where we have to put a stop somewhere. And if we don't do that, I think we're going to have absolutely a fertile ground. About 800, maybe more now, SNCUs are already, every district of the country, as sir mentioned, they are supposed to be 1,000. And there is wide variation in neonatal care. And that is what we have to look at. And of course, we have issues with the infrastructure and availability and training, what Subhadra talked just now. We need much more. So I think we did write a little editorial. I think Anand was part of this. And this is with our neonatology colleagues, two of them, one from PGI, another from US. The possible reasons are like improved survival, we already talked. But the basic problem is unrestricted oxygen usage, 100%. And we just want baby to survive some way. And that is where we have to do something. And that is why we need to include, and the model which has been propagated by Professor Azad. Of course, incidence of infection is very high, but at the same time, we come back to the same lack of awareness on the part of service providers. That is at all level. And very nice study shown by Professor Azad. I think we did change the guidelines because of some of the work which was done in our country, including Anand, which he published, which was part of his thesis. I think this helped a lot, because we have to show data. How do you change? And biggest stumbling block was neonatologists. They said we have to train, have so many babies otherwise for screening. But then look at this, what happened. 16% were more than 1750 grams. 6.5% were even more than 2 kgs. And 23% were more than 32 weeks. This is what helped us, in fact, because data from your country need to be generated. So finally, the guidelines which are from RBSK are now 2 kg, 34 weeks. And what should be done? You have to identify a single nodal person in NICU or SNCU. Who should identify babies for screening and communicate with the patient and ophthalmologist. Have somebody, because that is how you will have a much effective program. Combine screening with the visit for a neonatal problem. They usually call them for neonatal checkup. So you should also have that kind of a strategy, that you should same day, because they come from far off. And documentation, of course, is more important. Do prepare wall charts. Stick them everywhere. Whom to screen, where you have birth weight, you have when to screen, how to dilate. Very important talk today here in NICU, SNCU, nursery, OPD, everywhere. And of course, this one is very important. Subhadra has given him a slogan, "Tis din roshni ke," that if we can screen them, you see, with before 4 weeks, I think that will be ideal. 30 days is sacrosanct. Initial screening usually in the NICU, SNCU areas. Later, of course, you would do. And who should screen? Of course, ophthalmologist, well versed with indirect ophthalmoscopy and ROP. Biggest problem was indirect, hardly anybody was doing, but anyway, so now more and more are into that. But now telescreening and wild field cameras are coming in a big way. I think that is the future, and we know that wild field cameras can take, in one shot, they can be taken, these are portable, you can carry it, or your technician, nurse can do it and send the images. I think Anand deserves special mention here, and we all know about his telescreening program, not only in this country, but in many countries, his model is being followed, and which he has very effectively sort of utilized for this purpose. And he mentioned earlier in the session that if the baby is sick, you can screen through the wall of the incubator. So there's no problem, it is possible, and document according to the ICROP classification. And we have a problem, I think Professor Azad has brought this point, delayed screening. They come very late at this stage when already the fold is there, or mostly like this. There is a retina behind. Now, howsoever big the surgeon is, what will you do? We don't want them to go there. I think one study was done by us, another Professor Azad projected that study, and he has already shown this data. That is where we are. We have to be looking at these things. We have published both on the same subject of stage 5, and that is where we are. He already talked about it. So what should be done? Involve obstetrician, pediatrician, nurses, ophthalmologists, and parents. I think you have to involve everybody. If you don't do that, then we can't conquer it. And Indian Academy of Pediatrics, National NNF, as well All India Ophthalmology Society. IROP Society, of course, was formed with the same only because, thanks to Professor Azad for that. And Government of India, of course, he involved Government of India in a big way. And we are part of RBSK, 30 diseases. He included, I don't know how he included, because it's not a congenital disease, it happens, but it was his effort. And so I would say all healthcare providers involved in the care of preterm neonates should be aware of monitoring oxygen. That is very, very important. I think we are having biggest problem with this issue. And ROP screening guidelines should be known to all healthcare providers. The mothers should be counseled. Mother is the key. You see, if you have counseled the mother about the possible complication, implication of ROP, whatever it may be, she'll come. We have seen this. We have all seen. I've been into this 35 years in the ROP, this thing. And provision for timely ROP screening is something which must be made available. SNCUs are there. We have to have this. So I think we saw this impact of ROP screening. I had given my first thesis to a candidate in 1992. And subsequently, I also gave later after 20 years and kept the guidelines same. And we wanted to look at our own data. These was prospective both and later published. You see, in the first publication, it was 47.27%. It has come down to 22.7%, despite the fact that now more smaller babies are surviving. You see, that is the impact. If you have that kind of a interaction, it is going to come down, it's going to improve. So you can see it here. And this is after 20 years we have published these two things. So premature child is not born with ROP. I think you should remember that. And screening aims to identify, at least identify a treatable disease. That is very, very, we have a small window. So for treatment, we need to somehow act very fast. And delay cause blindness, we have, and these are medical legal implications are huge, and economic and social burden of childhood blindness is immense. So I would say in summary or in conclusion, lack of awareness about ROP in India need to be tackled. We have to work much more on that front. That is very, very important. And neonatal care and screening programs are variable, not optimal. I think should work on that front also. More mature and higher birth babies are developing ROP, and that is how it is happening because of the suboptimal neonatal care. And delayed or no screening, poor neonatal care are responsible for increasing number of childhood blindness due to ROP. Let's all get together, have dialogue, and I showed you how much difference it makes once you have that kind of a team which was suggested by Professor Azad. Thank you very much.
Thank you, sir, for that very insightful talk and with all your decades of experience. We'd like now to call on the next speaker, Dr. Anil Gangwe, who's going to talk about how to become an ROP screener, tracing the trail of training.
So good morning everyone, and thank you Professor Azad and Dr. Anand Vinekar for this opportunity to present our experience on ROP screening. So the topic allotted is how to become a ROP screening, and I would go with this because most of us would begin as a student or as a senior resident, as a fellow, and before we actually start doing ROP screening, as it is done with us, that it is told in MBBS that before knowing the disease itself, we must know the normal process or physiology. If it is very well understood by you, you will easily pick up the disease. So before that, we must understand the embryogenesis or retinal vascularization, and what is the role of oxygen or the pathophysiology of disease, and how actually VEGF is acting in both the ways, why it is responsible for physiological angiogenesis as well as the way it goes wrong, it can cause ROP. And we must practice indirect ophthalmoscopy in adults before we are actually planning for ROP screening, and get most important part is get a mentoring or training, at least if it is not possible for a long period point, but at least for if you are an VR fellow and have a good hands-on indirect ophthalmoscopy, you can learn at least good ROP screening with a mentor in 4 to 6 weeks. And if you are a general ophthalmologist, it may take slightly longer time, but you will be able to pick up a treatable form of disease at least in 2 to 3 months. And if you are good enough in screening or indirect ophthalmoscope, lasering the ROP or managing ROP will be much easier for you. So once you are a trained person and now comfortable in screening, then next step will be to get an access to NICU or SNCUs. So for that, important thing that you will need to understand that the pediatricians where you are settling or you are going to practice, they should know you. So how they are going to know you, you will need to visit them repeatedly. You will have to show your presence in their local CMEs. You can attend the IM, Indian Academy of Pediatrics, or NNF CMEs, and if allowed, you should try and present some latest things about ROP which the pediatrician may not be aware about. Recent topics like anti-VEGF, where they are also concerned, you can talk about such topics, then they will start knowing. And as Professor Dogra was also talking on this, we should make the parents aware about what is ROP, directly landing their children and screening them. You should make things available in most of these NICUs, or you can distribute this pamphlet in the NICU discharges. And as sir was also saying, we are sticking these kind of stickings to the NICUs, where the pediatricians as well as the parents of the children, they are able to see this, so that it can give some idea what the baby must go through. And once you are into one SNCU or NICU, you must understand the team with which you are going to work. The team definitely constitutes of NICU nurses, the fellows, and the neonatologists, but nurses play very important role in ROP screening and the subsequent communication with the parents. So we must understand, and we must educate our team, understand them and educate them why or what is ROP, why the entire exercise is being done. And it has to be done not only on a theoretical ground, but you must give some emotional impact, what is their role and how much they can actually play important role in prevention of ROP. So that is very important. We must train them that what is their role, how they can help us to dilate, the process of examination need to be explained to the staff. And after you have trained them, you must understand your own instrument, that okay, what all things you are going to do. And you are usually, I would start that we should start with indirect ophthalmoscopy, and once you scale up, then you can actually start doing telescreening as well. And initially, first starting ROP screening, you will have to reassure yourself that you are not going to harm the baby, because as a student, or most of us are not parents when we are starting ROP screening. So you may not be very much comfortable in handling a small and such a small neonate. So be assured that you are not going to harm the child. be comfortable with the children, and once you are into that, before applying the speculum to the child's eye, you must know that what is the appropriate gestational age and corrected postmenstrual age. You must go inside with a certain thing that, okay, if there is no ROP, I would expect that, okay, around 37, I would be expecting a mature zone 2. And if there is ROP, okay, there might be stage 2 or stage 3 and may need treatment. You must go inside with a certain mental picture. And you will need to learn how to see the anterior segment without using a slit lamp. So you will need to practice this, and you will need to identify certain things like corneal haze, poorly dilating pupil, tunica vasculosa lentis, NVI. And once you learn this, then the next thing that you should focus on is, without applying any depressor, you should learn to identify and see the posterior pole, because if you learn this, then it is practically impossible that you would miss any treatable form of ROP, because most of the things can be picked up, not all, but most of the things can be picked up from the posterior pole and the morphology of vessel at that. Then know the zones, and of course theoretically we will know bit of it, and understand the process of scleral depressor. Irrespective of the instrument that you use, you will need to understand that there is difference in the adult and neonatal sclera. The rigidity is very minimal. You would not actually need to depress to get an indent or elevation, and you will need to use this as a tool for maneuvering the eye, and that to see on either side of the scleral depressor, because doing this or understanding this skill will be very much helpful in doing ROP laser, because if you cannot see on either side of your depressor, there are very high chances that you laser on either side of your hill and miss somewhere in between. So this is an important skill which will help you to laser also. And the next thing is, I think we should, or as a trainee, we should learn to distinguish between vascular or normal or avascular retina by color. And color may not be a good criteria, because the pigmentation may take time to reach the peripheral thing, but we should try and trace the blood vessel which are normal retinal vessel. And if you are able to trace them, then identifying the ora serrata, that becomes very toughest. Actually, it is one of the toughest tasks to identify, because once you know how to identify the ora serrata in a preterm or a neonate, which is much posterior, which is much more anterior compared to adult, classification, the zoning, which will be much easier. And once you know what is normal retina, what is normal looking retinal vessel, then identification of the abnormal blood vessels, or that is ROP, which will be much more easier in the background of normal retina. So identification of ROP will be easier if you know normal retina, whether it is anteriorly located disease or it's a posteriorly located disease. Then of course with time and with your theoretical background, you will always know stages of the ROP, and as a beginner you should be able to identify at least first 2-3 stages. Next thing I think you will refer. Important and the most crucial part of ROP screening is, whatever you have seen, you have to communicate to the parents in the language that they understand. They must understand what is ROP and why you are going to treat that particular baby. So once you have done this, your journey will keep on going, and you will initially you would know the natural course of disease in terms of textbook, but if you want to really learn from yourself, you initially follow up your babies closely. That you will understand how it progresses from stage 1 to stage 3, and you will be able to monitor the natural history of ROP by yourself. Document the findings with very good records, because you will learn from your own records, and never hesitate to question yourself. If you are coming across some abnormal findings which you are not aware, please do not hesitate to ask and go to your mentors and ask about what is it, I am not able to justify it. And the process of de-learning, initially that certain things that we were aware and that you are treating with laser monotherapy, you will be very hesitant to learn something new. So the process of de-learning and learning shall always continue. I think that's it. Thank you.
Thank you, Anil. That was extremely practical, like a Hutchison manual. and very, very useful. Thank you so much for those insights. We'll keep questions for the end if we have time. I'd like to invite our next speaker, Professor Parijat Chandra from RP Center, who will sort of take the journey now of the 30 years of what's changed in treatment ideologies and modalities in ROP, whom, when, and how to treat ROP.
Honor again to speak in this session. Thank you, Professor Azad. Thank you, the panelists. So I will talk about who, when, and how to treat ROP and what changed in 30 years. So when I started as a resident at RP Center, the first thing which I saw in the OT was I saw Professor Azad doing cryotherapy, in a child. There was a big, commotion in the OT, and a lot of anesthetists were there, pediatricians were there, and cryo was being done for a very small baby. So cryotherapy was a very popular modality of treatment for a very long time. Also the multi-trial cryotherapy therapy also came in. And cryotherapy stood the test of time for a very long time. However, the problem was you needed GA. The child used to become sick after cryotherapy. And a lot of painful spots were given in this eye. And gradually it was replaced by laser. And laser then became the gold standard of treatment. The early treatment ROP trial has stood the test of time. And a lot of us still follow the ET ROP trial results which came out. And it advised type 1 and type 2 ROP. And type 1 ROP, which is marked by the red, is where commonly treatment is advised by laser for ROP. And this was typically how laser principle was applied, that you have avascular retina, you treat the avascular retina, and the disease will tend to go away. This article was written by some of the experts which you see also sitting here, and it advised good advice of how to treat with laser in these eyes. The problem basically was how to laser in aggressive ROP. A newcomer coming into ROP just didn't understand where is the ridge, where should I laser in this case. So we showed by angiography in some of these cases that the blue line is actually where the newcomer will think that he has to laser, but actually red line is where he needs to laser, because the whole area in between is just avascular loops, and the disease will progress if you do not laser in this area. Posterior barrage laser again became very popular along these years. Many people like to do posterior barrage laser in the hope of avoiding surgery, or in the criteria that there's some posterior vascular areas. And many of these cases, posterior laser did work very well in selected cases. Although in this particular photo, it's a little smaller zone. In a more anterior zone, posterior laser barrage will work very nicely in some selected cases and not in all cases. So this is typically how laser regressed zone 1 aggressive ROP used to look like, and someone has put in a lot of hard work to do laser in these cases. But the problem right now in this is that it leads to limited visual field, poor macular perfusion, and the risk of high myopia is obviously there. So what has changed across these years which has brought better treatment modalities in zone 1 ROP? So anti-VEGFs emerged over the last decade as the first line of treatment for zone 1, zone 2 posterior ROP, and it allowed for rapid ROP regression in these areas. And the huge benefit which it had was retinal revascularization, which laser could never do, allowing for a better visual field, better foveal structure, lesser refractive changes. And obviously it was a much faster, more convenient procedure to do for the surgeon and the baby as well, with less pain and a more stable baby. More and more regulatory approval has happened over the years, with ranibizumab getting approval from the European Union and aflibercept from the US FDA. And some of the current usage scenarios of anti-VEGFs, as has already been pointed out earlier, is that if you have a pupil like this which is not dilating, a lot of neovascularization is there, you give an injection in 3 days, this is how it dilates. So very good response is observed upon injection, and then you can do laser surgery or whatever you want in these eyes. So this is a magic drug in that way, that just has a wow factor when you inject it. A lot of the challenges with laser, like where to laser, this is case of zone 1 aggressive ROP. Again, you see that the macula is not vascularized. Where should I laser? How much to laser? So in these cases, again, anti-VEGF worked very well. So I'm just trying to show you here a case where a very small amount of posterior zone is here, and what to do in this. If you laser, you have to come in very close to this. However, if you inject this case, the the retina will continue to grow. So you don't stop it. You let it grow as much as it can, and then you can go ahead and do a combined treatment. In fact, now we are combining threshold laser also in some of the cases with anti-VEGF and laser. And sometimes if you've got a very bad ridge, it might sometimes lead to better outcomes if you combine the both. And because the laser is going to take time and the anti-VEGF is going to work very quickly. So however, some challenges are there. So which drugs to use? Because a lot of drugs are now available in the market. Biosimilars are available in the market. So we've been using biosimilar because in the government hospital supply for the last 2 years, ranibizumab is there with us. So there's no financial interest. But it has got similar results of earlier Lucentis, which we used to use. A lot of other biosimilars also now available in the market. People like to use half the dose, and although some of them like to use ultra low doses, 1/4 dose, 1/8 dose, but as you reduce the dose, it becomes more and more difficult to measure. And usually one injection works very well in these cases. I'm just quoting the study which was done by the IROP Society. A survey was done where they tried to show the common practices of ROP specialists, 157 of them, and they found that most commonly bevacizumab was being used half the dose. They like to do it in the OT, and they like to do it simultaneously in both the eyes. So injection-related complications are there because people are doing it in the ICU without proper sterile measures. And proper aseptic techniques. So you can have cataract and endophthalmitis. A lot of these cases are now coming up. So you have to be careful about that. Reactivation is a huge problem with anti-VEGF. So in around 6 to 12 weeks, the disease tends to come back. So you have to be careful about that. Keep a close follow-up, and if it comes back, you can do laser treatment and then do it. Obviously, it's been reported very well that ranibizumab has a faster and more reactivation than aflibercept and bevacizumab. And as Dr. Anand was also pointing out earlier, there's, managing power is a very important thing. Don't let the baby go away. A large amount of peripheral vascular retina if left behind needs to be treated so that the disease does not reactivate later and has later peripheral retinal changes. A lot of systemic concerns have been reported by many authors, and however the level of evidence right now is low and the benefit is huge, so we continue to use these anti-VEGFs. And I think this is what is going to happen in the future. Some telescreening model robot is going to go do a screening, and then the AI model is going to tell you, which case needs laser, which case needs to be injected. So this is what is happening, and this is what is going to happen in the future in the next coming few years, that the robots and the AI is going to guide you what is to be done, and this is going to be very exciting in the future, what's going to happen. The last frontier is ROP surgery. In these cases, again, the disease advanced beyond a particular level and retinal detachment is happening. So scleral buckling was done in a lot of cases across the last 30 years. And now the indications have reduced as MIVS has become more popular. But still, a lot of people like to do scleral buckling in some particular indications. For example, you see the photo on the left side where stage 4B sequelae is developing in the periphery. You will not be able to relieve it effectively with an MIVS. So possibly a buckle applied on that side, some people might like to do. This case came to the right side. He had forceps delivery, subluxated lens, a large break with the RD. So again, buckling might be a better option than just doing surgery like that. For MIVS, early intervention is the key. You should go in when the TRD is low. Low TRD, less peripheral TRD is there. Macula can be spared, and there can be less neovascular changes. So here you can do it, lens sparing surgery, easy instrument access, good traction relief can be done. When you are here, it's already too late. And we like to do bilateral surgery if both eyes are progressing simultaneously. It allows for single exposure to high-risk GA. Obviously, patient counseling is important and needs to be treated like two different surgeries. Basic principles are same. You need to do centripetal, vertical, circumferential traction relief. This is again the same case which I showed you just now. You need to, this is a 25G lens sparing vitrectomy happening. So you need to take care of this traction which is happening. Relieve this traction which is going to later cause the fold here in the retina. Relieve all the traction which is there over the TRD so that this can fall back. Don't worry about the bleeders because they can be dithermized and it can be taken care of there. And that's how you want to relieve all these three kind of tractions. And if you do good surgery, then the TRD is going to fall back and the traction can be very effectively relieved. Sometimes you like to combine anti-VEGF with surgery. And this kind of outcome can be only obtained when you combine both of them, especially in particularly selected cases. This is not recommended for all cases where you have a progressive TRD. You see extensive neovascularization is there on the left side. And it's already progressing despite laser. So if you combine both of them, you see such a clean outcome being obtained, which cannot be obtained just by surgery alone. Stage 5 ROP surgery, my teacher and mentor, Professor Azad, trained me in a lot of these cases, and I'm very thankful to him. And he used to deal with a lot of these cases, and as he's highlighted, the lack of screening is the major important cause. And a lot of these are, medical legal cases because ROP screening has not been done in these cases. And Dr. Vinekar has this whole series where he will, if you read it, you'll have an idea what happened in this. And so basically, this is how I like to do it. This 23G MVRs going in through which 25G instruments going through a clear corneal approach. And now we're going to do lensectomy here so that all this can be relieved. This is a retinal membrane. You go in an area where the lenses, where the retina is not attached in those areas. You can go ahead, continue to dissect, create bigger and bigger openings there. So the idea is most of these babies are left for blind. So it's better to go in and operate these babies in the hope of getting some kind of navigable vision. And as you see, as you continue to dissect into the posterior part, you can see the disc is there. The posterior pole is very shallow detached. And this is how the surgery would look like in the end in a sutureless manner. And just to conclude, so over the 30 years, what is still the best way to deal with ROP over these last 30 years is to prevent ROP. And the ROP is generated in the NICU. If you follow good NICU practices, then ROP will not develop. And even if it develops, it will develop to a very limited degree, which can be easily managed with laser. And that is the way to go. To prevent ROP is the way to go in the future. Thank you so much.
The next speaker is Anand. And I just want to remind the people for the next session, we were 15 minutes late, so we have 15 minutes more.
Thank you, sir. So I'm going to talk about how to set up an ROP screening program, or if you have one, how to expand it. These are 5 points that are given in the National Operational Guidelines, so that's Government of India's. It's available online, so I'm just going to summarize it with some personal experience in Karnataka. So firstly, if you are beginning to set up an ROP screening program, you have to do the need assessment, which is basically how many NICUs are there in your area, how many people are already doing it. So this is the national level. So we have 3.5 million babies and less than 200 ROP specialists. So this is when you talk to stakeholders, this is what you want to be telling them, because then they'll realize, oh my God, this is a problem. Many of them don't even think that ROP is a public health problem. So these are numbers that are available and you can extrapolate them. This is an editorial written where why is ROP such a big problem? And a lot of this you will have to convince your neonatologists or your medical colleges to set up an ROP division or an ROP unit or at least an ROP clinic. The next thing is to assess your at-risk population. So here you need to deal with neonatologists. Firstly, become a member of the National Neonatology Forum of your local chapter. As we've shown here, we've been able to reduce the severity of Zone 1 ROP in just 1 year of improving neonatal care practices, and that we did by creating a chapter in the NNF. So we didn't go as ophthalmologists and tell them how to do it better. We told the neonatologists to go and tell their own brethren how to do it better by simply monitoring their disease and publishing the downward trend after. This is another publication which eventually became the national guideline, where the first screening was advised before discharge. You don't have to wait for 30 days because many babies don't come back in rural areas. So if you screen once before they've gone home, at least you have the data of the mother and you can call back appropriately. And we showed 12 times higher follow-up and less attrition to follow-up. And the next thing is, of course, what are the reasons why they don't come back for follow-up? So 52 of them we published here, and some of them are modifiable, and the best way to do it is to expand your network. If you're able to screen in other districts through your teams, then when they follow up, if they go back to their mother's house or their husband's house, your team is there to pick up the screening. The next thing is the step 3 that is advised by Government of India is to assess the eye care providers. That's you and your fellows or your people whom you've trained or you're going to work with. Some of them are comfortable, some of them are not doing ROP. So world over, and this is something we all have to learn, that ROP screening programs have been a fairly big failure if it is completely kept into the hands of ophthalmologists. And these are reasons published by the London School. And as we go forward, it is supposed to be a pediatric-led model. So the more you empower neonatologists to call you, both the medical legal owners and the clinical logistics will become better managed. So what do you do when you have limited specialists? And this is the story all over the country, and this is where I'm going to share our experience of 17 years now in Karnataka, where we were trying to replace the so-called ROP specialist with non-physician graded certified technicians who are going to use wide field imaging. So this is the KIDRAW program, established 2007. We slowly expanded, and this is how every program we help to now mentor across the country or the world. We say start off with wherever you're comfortable with, wherever your friends may be neonatologists. It could be the private sector, and then slowly move on to the public sector. So from 3 hospitals, we are currently now at about 144. So initially we used the American camera, and then we've used the Forest camera, and this was a public-private partnership. So the best way to make your work most impactful is to work with the government, even if you are in the private work. And for that, you will at least need 6 months to 9 months of your own data to convince them that, look, I know what I'm doing. These are models that are already there. I'd like now to offer my services to the government sector. And yes, it takes a lot of going back and forth, but eventually now that we have models in so many states going on, it's going to be much easier. But back then we didn't have a precedent, so we were really helped by extraneous reports. So Ministry of External Affairs picked up the KIDRAW program, and the Harvard Business Review then picked it up, saying that this is a model that the West should follow because it's low cost, it's affordable, and it's highly expandable. And the next thing is, talk to business houses, talk about how sustainable it is. So both IIM Ahmedabad and Bangalore did business case studies on us and said, so we do free screening and free treatment for every baby born in a government hospital in Kidrop. And yet we are not only, we break even, but we are profitable enough to put back our money into our own research. So all the research that you see here is basically funded by our program. And that is done by a break-even cost. And we might be very poor in finances, but there are people who can do the work for you. So long back, this is the very first iPhone in 2009, if you all remember, the first pinch and drag. And I mean, today all of us are looking at these images on our mobile, along with so many other things. And therefore, the turnaround time is very important. If you are using telemedicine as a model, it will not be enough for you to go back with the report a week or 2 weeks later, like the EROP study did. You have to get back within minutes, because if the mother leaves the center and is not told that this baby needs treatment in a day or 2 or at least a week, then sort of lost the purpose. So Government of India then took it to the national, international level, and in fact, this won an international Innovations Award through Government of India's program. That's called the CAPAM Administrative Awards. So this is where we are now. We started at 3 hospitals. We had 144. We're close to 300,000 babies and over 4,000 babies that have been treated. Now, what's important is that this model has now got accepted. So those of you who still have that trepidation, oh, how can I allow a technician to go and screen in the rural outreach areas? This is, by the way, in the Government of India's document. So today, in fact, we are the first country to allow not just doctors, but trained and certified technicians to take these images in the rural areas. And this is the important word, trained and certified. So that's where you need to move forward and make sure that you've at least covered your legal basis. So this has been named by the United Nations Development Program and by the CDC. So Center of Disease Control, the Australian government actually studied the model because they were trying to see how to prevent costs of airlifting babies from the center of Australia and to take them to the 2 coastlines just for a 15-minute exam. And they said that telemedicine is the way to go. And this is from the Australian government report, not ours, which says that if you do indirect ophthalmoscopy and you're not adequately trained, you are opening up a Pandora's box of medical legal litigations. And this is important because we've had very, very large court cases against pediatricians, but also ophthalmologists in our country. So this was the cost barrier breaking. We worked with Indian industry, and this is the Make in India model 2014 onwards. It's not only a fraction of the cost, it's also more portable, and we've published the advantages as well. This subsequently won the BIRAC award both for the company and IIT Madras, who are our technology partners. I have no financial interest here because we served as non-paid principal investigators for that study, but we worked on a government grant at that time. And the new device now has an angiography model as well, which is very useful in the era of anti-VEGF. Now, how do we do the training and accreditation? So fortunately, before COVID, we had sort of mastered this area of doing it online. So nowadays, instead of spending 30 days, technicians spend less than a week or 2 with us, and the rest of the training happens online by correcting their posture, their methodology, and so on. But we still prefer 30 days, 4 working weeks. If they can spend with us, then we can certify them as trained technicians. And now we are working on 2 innovations. One is artificial intelligence. As we are going to be producing tons and tons of images, we are now, there are at least 3 publications from our group where the sensitivity is around 90-92%, but we are now in the process of integrating it with the telemedicine model. So as the technician takes it, the score comes out, and this we are not doing in isolation. We're doing it for Government of India in a BIRAC grant. And finally, this is what excites me the most. Our lab in Bangalore, we've been able to predict whether the baby will get disease or not by doing their tear fluid analysis during the first screening. We now have about 3 publications. This is good, but there's still work to be done where we are now prospectively following them to eventually come up with a risk score. And the 5th step is health communication, and this has already been deliberated by Sir, that the National Task Force and the, did an amazing job, and we were helped by the Queen's Diamond Jubilee Trust, but that was just the impetus. I think the real work has been through the Indian ROP Society, and we're in our 8th year now, and as Sir mentioned, from 32 members, we've now crossed over 200. And each of these are, dedicatedly doing a lot of ROP work, so they're not simply there for the academics. Let me give you one of our achievements, that we were the first professional society in the world within 7 days of lockdown in March of 2020. We put out how to modify the current ROP screening guidelines so that less babies are missed. And this, our guideline was, of course, not peer review published that quickly. We put it up on our website, but eventually peer review published. established, and it changed the way all our neighboring countries also did ROP screening. And the medico-legal liability is very big, and this is something that we need to know. This is one publication that we had in the Lancet recently, where we're taking from the successes of the polio program, and we desperately need a brand ambassador and many other things that we can learn from the success of the polio program. I'm just going to end with the impact you can make. This is a publication where we said if 9 other states which have a high ROP burden are going to follow the Kidrop model, what is the amount of blindness you can prevent? And that is used, that is calculated by the number of babies prevented from blindness into the life expectancy, into the per capita income. And India is only getting richer, stronger, and more healthier. And at least in the Karnataka model, it's over 4,000 crores of rupees that we've prevented. And this will be 10x more if we continue to do it in other states. Thank you so much for the opportunity.
Thank you very much, Anand. And I just want to tell the audience for the next session, including Dr. Virender Sangwani sitting here, that we started late. We inherited 15 minutes late, so another, 7 minutes. Please go, Karavi. You have 7 minutes. We just finish and hand over the session to the next chair.
Not the end of the road. Thank you, Dr. Azad, for giving me this topic. Not the end of the road. Rehab, resources, and recent advances. A lot of it has been covered already by Sir and by Anand. And when we say not the end of the road, certainly not, because with the betterment of neonatal facilities, increased survival of small neonates, situation today stands at betterment of treatment facilities, more in-depth know-how, better awareness from a multitude of committed ROP specialists, spreading awareness throughout the country, and early screening referral from pediatricians, from awareness to them, timely aggressive treatment and early rehab to improve the global development of the child and minimize disability. At this point of time, I would like to appreciate our icon, Dr. Rajvardhan Azad, for taking it in the last 30 years from a point where it was a small, minuscule project to somewhere where it is now, where the number of ROP specialists grew from a small number of 3 and 4 right up to 233 as it lies today. This was joined in by Professor Mangat Dogra and later by Subhadra and Anand to bring it to the status that it has come today, because today it is a worldwide problem. Just seeing the numbers in this audience tells us how it has grown exponentially and how we are able to communicate with everybody, because this awareness program also, which was brought forth by Dr. Professor Azad, has also helped the inmates of the AIOC Society and the people who are practicing ROP to sort of spread awareness in their localities so that it becomes a multi-center project. Now, there is not much time, but I would like to say that this rehab is something which is very important, because there is a rapid assessment of avoidable blindness, which is a population-based survey that drives to prevent avoidable vision loss through collection and interpretation of high-quality data, because the numbers that become blind every year is massive. That is 500,000, one every minute. And the mortality also is the same. Now, when we talk of rehabilitation, we have to rehabilitate because higher number of children are sort of surviving this now. And the neonatal care, though it has improved, in certain areas it is compromised. There's lack of screening and treatment because the burden is high and the numbers that really do it are less. So here comes the situation where we have to have other trained personnel who go in to these outreach areas and they photograph by the telescreening techniques which Dr. Anand Vinekar has built, and they train these people in their own setups, and he is now increasing the number of these programs not only in Karnataka, but he's also doing it all over India, which I think that is his current baby just now. And it is not the end of the road, because the thing is that there is a lot to be done in this. But what we find in these children who have ROP, they have a great association with neurodevelopmental disorders. And these neurodevelopmental disorders run up to almost 68.4% in these children. And that is the reason why we have to address them, whether they have mild delays or moderate delays or severe delays. And these have to be addressed not later, but as the child is in the NICU, because you have to know that at that point, if you target it, you're going to sort of prevent a lot of problems for the child and give him normalcy to continue. So the Ministry of Health and Government Welfare, Government of India Resources, that is the RBSK, they have formulated guidelines, and they have these district level centers which cater to identification and management of 4Ds, that is defects at birth, deficiencies, diseases and developmental delays and disabilities. The initial step of deputing trained and dedicated mobile health teams for screening and children up to 18 years of age selected health conditions under the RBSK, and this is very important. Now, when we talk about resources, the resources, there were 2 Indian-based studies which showed that, there was like screening per cost was about 253, and per infant it came to 6,500 vis-a-vis 1169. And as Dr. Azad also has shown you, that it is 2,000 rupees worth several dollars in the West. So the thing is that our costs are low, our numbers are high, but we have to make a bigger effort at trying to control this, because this is a major project, and this is something which we are really going to help the little neonates in. Now, these resources also sometimes come from the major trusts, that is the Sight Savers Group or the Diamond Jubilee Trust, or there is a Japanese trust which is also there, and these people are ready to fund, provided they know that the person who is taking on the onus of taking that funding or the machines, that is the telescreening machines, have to do justice to it. So they have to be convinced before they kind of sort of agree to it. Now, in the recent advances, visual impairment at a young age has lifelong consequences. So the advances have to be not only addressed in the form of what kind of advances are there in the technical part or in the disease per se, but also in the visual rehab. Now, the RBSK has a center which has a holistic approach to children, and this is age appropriate level because they cater to less than 18 years, but the more emphasis on children who are less than 6 years, where they have areas which have domain specific equipment, trained personnel, and other specialty people like dentists, optometrists, audiologists, psychologists, physiotherapists, vision therapists, and such a center would act as an apex center of the disease. And their goals are simple. They have to target these children and do good to them by diagnosis, intervention, referral, and prevention of psychosocial and also psychosocial interactions. So this is how they get all their children. This is the major kind of a thing where they then, the referral is there, and they review, and then the follow-up is there. And these are general guidelines of how they manage this kind of thing, because it is a very labeled kind of format which goes through the clinical examination of these children, and the help that each one requires is tailor-made to them. And this is at the District Early Intervention Center, and this caters to community early intervention. So they target general examination, gross, motor gross fine reflexes, speech language communication, receptive language, expressive language, associated abnormalities, cognition, social emotion, and play. And so in short, this is what the DEIC does. And they target sensory integration, which controls all our 5 senses, along with the tactile body position, sensory integration, and the balance activities for the child. So it is an interdisciplinary approach and a transdisciplinary approach, not a multidisciplinary approach, because multidisciplinary caters one-to-one, whereas this has to be an integrated activity of all the groups put together. So these are just a few examples of how they do it. And they say that this is not a drug or a vaccine, it's not a device, it's a group of therapists working together, solving problems and enhancing capabilities. Now, the early rehab, as I said, starts in the NICU. Now, newer predictors, apart from the gestational and birth age, they have had certain neonatal scoring systems, but they have not been of much value. But the important thing is that low weight gain, less than 32 weeks, if it is not less than 50%, this is a high predictor for severe ROP. The WinROP also addresses it, that the level IGF-1, if it is less, it is this. Now, just to run over a few things, the telescreening, a lot has been said of it, and we know a lot of it from the KidROP model and the other models, like the one which is there with Dr. Ale Banka, the Rotarop, and the one which is with Sucheta. There are more centers that the RM is starting. These people have taken it to a different level altogether. Then newer therapies like propranolol, then that is also supposed to have good effects, and the IGF level ones, which is kind of, they are treating with concentrations of IGF-1 and IGF-BP3 because it's found to be effective. And the parenteral nutrition, which is also very important in these little children, because if they are not undergone good nutrition, just a few more slides, sir, 2 to 3 more. The omega-3 fatty acids, the E-lipids, the gene therapy also has been spoken about, and the visual rehabilitation, of course, deals with the primary senses of the children, and they target the survival reflex, the sucking, rooting, and snout reflexes. And last but not the least is the artificial intelligence, which can demonstrate intra and intra-expected subjectivity, and it has a kind of specificity and sensitivity of almost 90 to 95%, and it improves the efficiency, accuracy, and objectivity diagnosis, and facilitates quantitative disease monitoring and risk reduction. That's all that I have to say. Thank you so much.
Thank you much, Karobi. And I'm really thankful to the chair of the next session for allowing us this time. Thank you very much. We'll just have a small photo and then go.